So here my disclosure. So for the interventional cardiologists in the audience, how many of you think this is a mid-RCA severe calcified disease? I had to cross the lesion with the FILDOR-XT wire and the crossing catheter. How many of you think we need an atherectomy here? So I thought that we definitely need atherectomy here. Patient was randomized in a prospective randomized controlled trial on ECLIPSE, and patient got randomized to balloon angioplasty. And to our surprise, a 3 millimeter balloon inflated at 4 atmospheric pressure, and we got a complete expansion of a stent with a very good angiographic result. So the importance of randomized controlled trial in a severely calcified SFA popliteal disease is not really established. And so, the so-called master approach is not truly evidence-based approach. Having said that, there are 7 different scoring systems that we can use to define the severity of the calcium. But all of these scales are kind of hypothetical and not driven by the prospective educated trial outcome data. Use ultrasound or OCT, and that can help you define the location, whether it is concentric, eccentric, adventitial, and the degree and the extent of the calcium. But availability and reimbursement are definitely issues. And therefore, what happens is despite the fluoroscopy has a limitation, it does not it underestimates the extent and the location of the calcium, but most operator kind of relies on the fluoroscopy and angiographic appearance to plan their approach and the treatment. So when it comes to wiring the severely calcified disease, I would say try to understand this as a lot of time what appears like 100% occluded artery can be still have this serpentile micro channels. So generally speaking, I would say start with a very torqueable wire. Also use your crossing catheter position appropriately. Continuously advance your crossing catheter as you have more ground gain with your torqueable wire. And when it comes to the true lumen versus subintimal plane, true lumen always, I think, helps as you can modify the calcium appropriately and get better expansion of the lumen. But if you are in the subintimal plane, just remember that your re-entry device's choice has to be appropriate for the severe calcium. So in this example here, trying an antegrade approach, we are not able to cross even with a stiff wire and enter back with the anterior device. And when it comes to wiring antegrade versus retrograde, I'm a big fan of retrograde wiring. So in the same patient, we came retrograde from the distal, and again you can see the wire catheter position. We easily crossed that from the distal or retrograde approach and ended up doing orbital atherectomy followed by the stent. When it comes to atherectomy, the randomized and the observation studies has showed that it improves the technical success, and particularly if you want to stop with the drug-eluting balloon only, then it prevents the bailout stenting, but it is coming with the expense of periprocedural distal embolization. And there is no dedicated randomized control trial for severely calcified SFA popliteal disease. So when it comes to the atherectomy use, our goal is to fracture the concentric calcium that will allow adequate expansion of the balloon or stent, but our also goal is not to cause distal embolization. So when it comes to the distal embolization protection device use, I say all atherectomy devices a different risk of embolization. Also the disease has different risk of embolization. So you want to wait particularly for the case and the severity of the calcified disease. But we definitely know that if the calcified plaque modification is done, then you can improve the drug delivery if you are planning to treat just with the drug-eluting balloon. So when it comes to the atherectomy, what I have not included here is the lithotripsy balloon, but rotational directional laser or orbital atherectomy, and each one has its advantage and disadvantage. But when it comes to severe calcified disease, I kind of tend to lean towards using orbital atherectomy. And it's very important that you use appropriate size of the burr and also you follow the protocol. So I generally speaking would say whenever you see this kind of severe calcified disease, and this is a patient who had high risk for surgery, that's why we ended up treating this common femoral disease. But it's very important that you advance your atherectomy device very, very slowly, have complete patience, because the slower you advance your orbital atherectomy device, it will convert it into the much smaller profile of the calcified dust that will less likely to cause outflow obstruction. So if you think that your wire is maybe subintimal, so here is an example where I was not certain if my wire was subintimal or was in true lumen, and if this was a eccentric calcium or not. These are the kind of places where I use directional atherectomy with the concern that I'm not going to tear the vessel. But generally speaking, when it is concentric calcium, I tend to use more of orbital atherectomy. It's very important to, after atherectomy, dilate the balloon aggressively, and very important that irrespective of your destination therapy, you do 1-to-1 sizing. You don't want to oversize. Prolonged inflation does reduce the dissection and causes smooth muscle cell dysfunction, so you basically do not have recoil as much. And when it comes to scoring balloon, I kind of tend towards this success from Mehdi about the pillow and the groove over conventional scoring, and reduce risk of flow-limiting dissection with the chocolate balloon over the other cutting balloon or scoring balloon. So how should we end? There's a whole lot of a discussion with the drug-eluting balloon, leave nothing behind. But when it comes to this kind of severely calcified disease for this patient, we did the retrograde approach, we crossed through the lesion, we did the orbital atherectomy, drug-eluting balloon. Was a very good acceptable result, but this patient came back in 7 months with recurrent of the symptoms. So again, we went retrograde, and you can see the severity of the calcium despite a very good angiographic result with very aggressive atherectomy and balloon angioplasty. Recurrence happened, and we had to do the same over again, and this time we ended with the stent, and this is about 1.5 years, and this patient has been doing well through the surveillance. So what I do not have here is the lithotripsy balloon, because we just had that become available recently for us. Do not have good case example, but obviously from the previous speakers we saw that that's an absolutely very useful tool as we are understanding and more data is coming out. With that, I'd like to end here. Thank you very much for the opportunity.